Assalamu alaikum. The short clinical day. First station, neurological examination. Please examine the patient gait and proceed accordingly. Dr. Sarah, you can start now.
Yes, okay. Hello,
Hello.
I'm Dr. Auda Karim. I'm one of the doctor candidates for exam today. Can I examine you during our examination? If you feel any pain or discomfort, please let me know. Is that okay?
Okay, doctor.
I wash my hand first. Okay.
Okay.
So, yes, could you please, can you you walk for me?
Okay. I've sent the working gate to Dr. Bazin. You just show it to you in your picture.
Here it is in the chat box I sent, but I don't know if she can
Okay.
understand.
Yeah,
Okay.
okay. Okay. So, okay. Yes. There's a stupid butcher. Okay. Like short shoveling it. Okay. Yes, I will start to examine the hand if there is any hand tremor.
So give me instruction. How do you want to go about it?
Yes. Please. Just first, I will look if there is any hand tremor when at rest position.
Okay. There is, but not very prominent. What do you do to make it prominent if you want to do it?
Yes. Could you spread your hand for me, please?
Okay, I've stretched my hands.
Mm-hmm.
Nothing.
Okay. Any hand tremor when
I'm
at rest?
stretched. No tremor on stretching.
Okay. No tremor at rest. Okay. So I will do. Yes, I will do. If there is any syncytial, please,
Okay.
please, if you can, tapping this hand in your
Which one?
thigh.
Okay.
Okay, I will
I've
observe if there is any the hand tremor it appears while the patient tapping.
Which hand are you looking for? Is it the hand I'm tapping that you're looking for?
What?
Which hand are you looking for tremor? Is it the hand that I'm tapping?
Yes, the right hands. Where is the hand tremor exactly? In the right hand or in the?
You will check. Which hand do you want it to appear? There's tremor.
Yes, the right hand.
Okay, I should tap the right hand, right? I'm tapping the right hand. There's no
I will
tremor on the
tap.
right side.
I will tap the left hand.
Okay, I'm
And
tapping the left hand.
yes.
Okay. Just some small tremor coming up, but not very well.
What?
Some little tremor is seen in the right. As I'm tapping the left hand,
In the
some
right.
little
Okay.
tremor is
Yes.
seen in the opposite hand, but not very prominent though.
Okay.
What else do you want to do?
Okay. So I'm going to check the movement. If there's any slowness of the movement, could you please can you move your thumb to touch others the tip of other fingers?
Okay, I'm touching the tip of other fingers. Okay,
Mm-hmm.
all right, I'm doing that.
Okay. I'm going to check for the rigidity
Okay,
for these patients at the level of the elbow.
okay.
Yes.
Yeah, there's
Lid-
rigidity at the elbow.
Yes, there is lid pipe
Yes, there's
rigidity.
leg pipe rigidity. Yes.
Okay, at the level of the wrist joint.
Mm.
Okay, there is rigidity.
Yes, there is. There is.
Mm-hmm. Cogoid rigidity. Okay, so I'm going to check for the pronator drift for this patient.
Pronator
Could you
drift.
please, yes,
Okay.
can you extend your both hand for me and close your eyes, please?
Okay. It's normal both side.
Mm-hmm. Okay, I'm going to check for cerebellum examinations.
Okay. How do you want to go about it?
Okay. Yes, by this diadokinesia, if you are able to do it like
Uh,
this.
what should I do?
Yes. Could you tap your both hand in the opposite directions like this?
Both hand, opposite direction. Okay.
Yeah.
Okay. Nothing.
Okay.
Normal. On the
Okay.
right side.
Okay. So I'm going to examine. Yes, I am going to look for the face if there is any facial expressionless face, and
Okay.
also
The
yes, if
face.
there is any.
There's a face. I'll show you the face. The face, and
Mm-hmm.
Dr. Bazin will show you the face now.
Okay.
Mm.
I'm going to check if there is any drooling of saliva.
Okay. No drooling of saliva.
Mm-hmm.
1 minute left.
Okay, I'm going also to check. Yes. Okay. I'm going to check for the yes, the vertical gaze for these patients.
How?
Please, could you follow my fingers? I'm
Okay.
going to move my fingers up
Up. Okay.
and down.
Normal.
Okay, and also I will do H-shape movement to look for if there is any nystagmus for this patient.
Okay. No, no,
Okay.
okay. Normal.
Okay. Okay. I'm going, yes, to check the writing. Please, could you write your name for me in this paper?
Okay. It's very small. I'm writing, but it's small.
Yeah. Okay. So could you give me the full name?
My full name,
I'm going. Yeah, I'm going to check the speech.
John Smith. John Smith.
Mm-hmm.
My name is John
Okay.
Smith.
Okay. Thank you. Okay. So I'm going. Yes. Also. Yes. Please, I will give you this pen in your hands. To check, are you able to identify it? What is it exactly?
No, I can't. I can't.
Okay, okay. I will do. I would like to check the blood pressure in this patient sitting and standing. If
Okay.
there's any postural drop.
Yeah. Yeah. Yeah.
Yes,
Mm.
there is. Okay, and also I'm going to check. I would like to check the memory for this patient also.
Okay. Skip.
Mini-mental status score. Okay, okay.
Okay, I added 1 minute to finish your exam. You want to examine
Mm-hmm.
something else?
Um.
You did the H
Okay.
shape, right?
Yes, yes, I did.
And what's missed in the H shape you want to do?
Um, yes, the visual acuity,
No,
no need visual
something in the
acuity.
movement. You examine the
Yes,
all movement for nystagmus. Any
yes,
specific movement you want to check?
I did it regarding the vertical gaze.
Okay, you did it. Perfect.
Yes.
So the time is up. Let's
Mm-hmm.
start the exam question. Dr. Henry, you can start now.
Can you please present your patient?
Mm-hmm. Okay. On examination of these patients, yes, on examination of these patients, he has sign going with Parkinsonian features in the form of yes, stupid posture, short shuffling gait with loss of arm swing, and also he has facial expression less face, also drawing of saliva, and apart from that, he has resting tremor in the right side, be rolling, okay, asymmetrical, with synkinesia and bradykinesia also, and there is rigidity. The rigidity at the level of the elbow, which is the lead pipe rigidity, and the level of the wrist, which is cogwheel rigidity. Okay.
Okay.
Apart from that, I could not appreciate any other finding in our examinations. Okay.
Okay. Okay. So, what are differential diagnosis?
Okay, my differential diagnosis: this patient most likely has idiopathic Parkinson disease.
Okay. Other differential diagnosis.
Yes, other differential diagnosis could be vascular. But again, is that yes, I need to check if this patient he has any ischemic risk factor like hypertension, diabetes, smoker, hyperlipidemia, and also yes, post-traumatic and Parkinsonian plus syndrome.
Okay.
Mm-hmm.
So okay. So what type of gaits do you experience in this patient now? What are the other type of gaits that you know, and give example of each?
Yes, fascinating gait,
Okay.
short stepping, shoveling, with lots of arm swing.
Okay. So which other type of gaits do you know, and give example each?
What?
Outside fascinating gaits, which
Yes.
other gait abnormality do you know, and give example each?
I didn't get you. You mean in this patient or
Other,
Not
in
no,
in
no,
this.
general?
other patient, other gates, you know, other gates.
Other gate, yeah, okay. So other gates like white base gate and also like scissoring gates.
Yeah,
Okay.
specify
Uh,
each cause for each
yes,
gate.
yes. Spastic paraparesis. It can cause scissoring gate. Okay. And also broad base gate like proximal myopathy it can cause it. And also high stability gait like the distal weakness also um yes, and ataxic gait like cerebellar infection.
Okay. All right. What are the non-motor manifestation of your diagnosis?
What?
What are the non-motor manifestation of your diagnosis, of your first diagnosis?
Non-motor manifestation of Parkinson.
Okay, non-motor manifestations. Okay, non-motor manifestation of Parkinson disease. Yes, extrapyramidal. Apart from extrapyramidal, like speech, maternal speech, and also drawing of saliva, and also uh, the writing.
Also, what? I didn't get the last one. What did you say?
Okay, what?
I did okay, it's okay. I didn't get your last statement. So my next question is,
I
how do you
didn't
differentiate?
understand the question exactly, actually.
Oh, it's
Mm.
okay. How do you differentiate between
Mm.
progressive supranuclear gaze palsy from
Mm-hmm.
idiopathic Parkinson? What are the difference?
Okay, progressive supranuclear gas palsy from idiopathic.
Yes.
Okay, regarding the vertical gas, there is vertical gas in supranuclear gas palsy.
One.
Yes, in idiopathic not found.
One.
Mm-hmm.
Any other difference?
Other differential,
Any other difference between PSP and idiopathic Parkinson?
yes, autonomic manifestations like postural drop and also cerebral infection.
Well, okay.
Mm-hmm.
All right. Any other thing?
In the progressive multiple system atrophy or
Not
what?
okay. It's okay. Mm, All right.
Ask about investigation and management, Dr. Henner.
Okay. What are the investigation you do to diagnose your patient?
Yes, regarding apart from the general workup, I will do for this patient's investigation, like yes, like yes, like PET scan. Uh, yes, I will do MRI brain, SPECT scan. I forgot it, or data scan. Okay, MRI brain and SPECT scan, and also I will do other like tilt table test for autonomic. and other tests to look for if there is any.
It's okay. So how do you manage this patient?
The management, non-pharmacological education and counseling about his conditions, MDT. Okay. MDT includes neurologist and physiotherapist and occupational therapist and speech and language therapist. Okay. And yes, regarding the treatment, I will give this patient levodopa replacement or replacement therapy, symptomatic therapy or replacement therapy. Okay. Replacement therapy, levodopa or carbidopa, and الCOMT inhibitor, and MAO also, dopamine agonist also. Symptomatic, I will give anticholinergic. And surgical, also deep brain stimulation
Okay.
or lateral stylotomy.
It's okay. Thank you very much. All right.
Yeah, thank you.
Um,
Well done.
thank you very
Let's
much. You.
comment Dr.
Thank you.
Henry, please.
All right. Thank you very much for the wonderful. Your approach was okay. You did very well. Generally, you did very well. But let me just comment on some few things that require, some adjustments, and that will make your mark to be really good. In terms of when you're expecting the patient, before after you take permission, you take consent, you look at the patient generally. You should have do a general inspection where you look at this if there's any presence of scar, look for any evidence of wasting, you inspect for any fasciculation. As you are inspecting generally, you check for any evidence, the environment, if there's any mobility aid, like walking stick, wheelchair, this will give you a clue, about the patient's gait. That will give you a clue. So by mere looking at the general inspection, and also, in terms of the gait, you talk about the posture, like you mentioned, stoop posture, which is lovely. You check about the if there's any increased arm swing, decreased arm swing, which you check, which is good. Then also, after you've done the gait, you should ask the patient to sit down, because Parkinson disease examination is done quite seated, because the patient is having some gait problem, hopefully. So you must ask the patient to, please, can you please sit down? And patient is seated, then giving pillow to put on his leg, on his lap, then he can rest his hand on the pillow. That gives you a broader view on how to better inspect the tremor very well. After doing that, you look at the face. Like in this patient, the patient is having seborrheic dermatitis. If you look at the face very well, have you seen it? Dr. Bazin, can you show the face again?
Yes,
The
in the
patient is
chat
having
box.
Yes,
Yeah,
yes,
there is
yes,
in the chat box.
yes,
is
yes.
having seborrheic dermatitis, which is one of
So
the
I didn't, yeah.
you didn't recognize that.
Concentrate. Yeah.
You are just, and that is where many of the questions lie. But since you didn't mention it, I just, drop back and give you ask
Mm.
that question. So that thing alone is a clinical sign that the examiner wants you to see and to mention. Because my next question was to ask, I'm going to ask you was, what other condition you might see this seborrheic dermatitis outside Parkinson disease? Which other condition are you likely to find this condition, this skin condition of this man? That is HIV is another condition you can find it. Then after looking at the skin, another thing we want to do, look at you mentioned, okay, the mask-like face, beautiful. You look at the eyes, ask the patient to close his eye, check for what blepharospasm, check blepharoclonius, sorry. You know, then after that, you look at the the ask the patient to do the up and down movement, which is the gaze, which is you did that. You try to rule out PSP and the nystagmus, which is multisystemic atrophy. You multiple you did that. Then the mouth, you act, which is good. I love the way you talk about the hypophonia, in which you elicited from me. Then the issue of the tremor, you did that very well. The bradykinesia, you did that too, which was good. You will have cerebellar sign, which is also good. You will have micrographia, which is good. Then also the pronator drift, wonderful. I gave it thumbs up. You try to also do that too. But while you are trying to rule out those bradykinesia majorly, you do for both the upper limb and the lower limb to rule out vascular dementia, which is tend to be worse in the lower limb than the upper limb. You should have done that too. Then also, like, in case there's no time, after you've done all the things you've done, like the issue of the posterior and then the pulse test to test for posterior, instability. You should have asked the examiner that these are other examination I want to do may include posterior blood BP check, pulse test, to then mini mental state examination, just to cognitive, so to complete your diagnosis, because those ones will take time for you to do. So you just tell the examiner that you want to complete your examination. I would love to do cognitive testing, posterior BP, and then pulse test. That will further complete your diagnosis. Then by and large, when I was asking about the PSP difference from idiopathic Parkinson, you mentioned tremor at rest, which is good, which is present in idiopathic but is absent in PSP. Stoop posture, present in idiopathic, absent in PSP. Response to levodopa, present in idiopathic, absent in PSP. Backward leaning, backward leaning, the person tends to fall backward in PSP, unlike in idiopathic, person falls forward, which have this forward leaning in idiopathic, while backward leaning in PSP. Then vertical gaze too. Vertical gaze is seen, which you mentioned in PSP, is absent in idiopathic. Then also the when you do your MRI, it may tend to be normal in idiopathic, while you may tend to see midbrain or Humenberg abnormality, which is there's a atrophy of the midbrain in your PSP, which is called the Humenberg or pencil sign shape you see there. Then also the protein that's abnormal in PSP is tau protein, while for idiopathic is alpha-synuclein protein. These are some other difference that in case probably your differential diagnosis, you mentioned PSP, we tend to rule them out. Then and also I think by and large you did very well. This is just some few addition. I just needed to just say it. I think other thing, I think you did well generally. Yeah, you did well.
Okay,
Thank you.
thank you, Dr. General. Yeah, it's a tough case to comment on the face appearance or the redness or the rash while they ask you to examine the neurology or the gait or the motor or anything else. Yeah, you have to mention it, but not in details. I don't know what the relation between the redness in the face and the case. Is it polycythemia, for example, with a stroke, or just occasional?
Seborrheic
Dr. Hina?
dermatitis.
Yeah.
Okay, as association.
Actually associated with, yeah, in Parkinson's
Okay,
disease.
yes, I got it now. I thought it's redness for the polycythemia rubra.
Yeah.
Okay. Yeah, so this is an association, should be mentioned. Thank you for that. The other thing, the two-step backward is very important, Dr. Sarah. Don't forget to do it before starting the examination. Why? Because the surrounding here is very important. Either you will have a stick or you will have wheelchair, as Dr. Henry mentioned, and you have to notify it to the examiner, either to point to them or to mention them while presenting the patient. So while examining this patient, I found there is a wheelchair, there is a stick beside the patient. Even the posture, you can say, I can observe the specific posture for the patient or any particular position. Then the gait, yes, it was clear that it's a shuffling gait for Parkinson, and it will take time, but you have to start with, because this is the instruction, start with the gait. Let's comment about the other types of gait. I think you mix between the gait and the cause of the gait. So the shuffling gait, as in this scenario, it's Parkinson, right?
Yes.
And the other type of gait you mentioned, spastic gait, right?
Mm. Yes.
Associated with what? You
It's
said,
spastic paraparesis.
yeah, spastic paraparesis with either,
Mm.
according to the cause, for any
Yes.
reason. Yeah, so it's spastic paraparesis.
Oh, yes.
The patient will have the spastic gait or scissoring gait, right?
Yes.
Scissoring
Yes.
gait.
Yes.
The next gait will be
Mhm.
high steppage gait, associated with what?
Distal weakness.
It's peripheral neuropathy.
Yes, peripheral neuropathy, I mean,
Yeah,
yeah.
peripheral neuropathy, not distal weakness. Okay. Then you mentioned the widen, right? Wide gate or broad gate, and you mentioned proximal.
Waddling gait
Okay,
for
waddling. Okay, yeah,
for
waddling. Yes,
proximal
I heard
myopathy,
it wrong. Yes,
broad
yeah,
gait
waddling.
for the cerebellum.
Exact.
Yeah.
Yeah, waddling gait with proximal myopathy, and the next is the wide gate or broad
Yes,
ataxic gate with cerebellar.
cerebellum. Yes.
Yeah, these are the cause or the manifestation or the known gait abnormality in paces. They might ask you, but it's not commonly to be asked.
Mm-hmm.
So you can specify the gait according to the case, but they will not ask you what other type of gait. However, you have to know them. Okay,
Okay.
the next thing in this scenario, and he asked you about the non-motor symptoms
Mm.
of
I didn't
Parkinson.
understand actually. Yeah.
Yeah, yeah, there is non-motor like sleep, disturbance, GI.
Mm-hmm.
Okay, all this can be as non-motor.
Mm-hmm.
The skin and as you mentioned here in this scenario, skin manifestation,
Mm-hmm.
the blood pressure as in multisystem atrophy. Okay,
Mm.
these are the non-motor symptoms of Parkinson. The
Okay.
next question was about the investigation. You start with the image directly, and advanced one. Why you didn't start by doing the all blood test?
Just add routine for this
Yeah, as
patient.
routine, but you didn't, for example, you didn't mention the lipid profile because you suspect vascular type. So you have to suspect,
Yes.
you
Yes. Diabetes
investigate.
screen.
Always start with the simple baseline test. If he asks you, please, doctor, give me an image or give me specific test, this is the time to give him specific test, for example, PET scan.
Mm-hmm.
But in this scenario, or whenever you start with the investigation, start with the blood test or the lab test. So you can say the even the coagulation profile makes sense to do it. Patient might have hypercoagulable state, and he has, for example, vascular cause. Vitamin screening you have to specify also,
Okay.
and yeah, to add to the urine investigation, always whenever you have neurological case, always mention the vitamin screening. Okay.
Yes.
The other thyroid function we mentioned and lipid profile you have to do. I would like to take full history. What do you think the importance of taking history from these people? What
Yes.
important history you want to take?
To identify just if he has idiopathic or Parkinson plus or vascular, to know
So
the
yeah,
cause. I mean,
what particular history you want to take or to ask about? Past
yes,
medical history
past medical history.
of
Yes, these
stroke,
are
for
the
example, right?
yes,
The onset and the course duration, the symmetry or asymmetry,
mm.
the drug history. Is it important to mention the drug
Yes. It's
history?
important because sometimes drugs
Yeah,
can
so
cause some like
yeah,
medical
always
bromide
exactly some medication and psychotic and
and psychotic.
anti-epileptic,
Yeah.
yeah, anticonvulsant. You have to say, I would like to take history, full history, family
Mm-hmm.
history as well. All this makes sense to say it before even investigation. Okay, even
Okay.
while doing this, while taking this history, you might diagnose the patient,
Mm-hmm.
right? Okay, next, the other investigation, the image we mentioned already, MRI also to rule out vascular cause.
Yes.
Yeah, the management plan will be added through multidisciplinary team approach, including the neurology and neurosurgery,
Mm-hmm.
as well as the physiotherapy, the SOL team, as you mentioned.
Yes.
So it's
Yes.
important here also. And for the long term, physiotherapy, occupational therapist, right?
Mm-hmm. Yes.
Okay, the management plan already you covered all replacement for dopamine, either carbidopa, levodopa, or COMT inhibitor,
Mm-hmm.
monoamine oxidase inhibitor, and anticholinergic. I think this is the Parkinson, and always it comes as tremors or first time to hear about it. Examine the gait, but what I know the tremors. patient. Examine the upper
Yeah.
limb, for example. The cogwheel and the lead pipe you have to mention, while synkinesia, the tremors type, bell rolling, all these you should mention and you should examine while doing the examination. The supranuclear palsy, the gait, the downward gaze you have to examine as well. The micrographia, yes, the speech, monotonous speech, you have to ask about the name. I think you did
Mhm.
full examination of the Parkinson manifestation. Any missed point, Dr. Henry, or you want to add?
Like I said, she did very well.
Yeah,
She did very well. Yeah.
okay. If Dr. Rabia with us, anything she want to add? Dr. Rabia, anything missed regarding
No, no,
neurology?
Dr. Bansi, you covered everything. Usually, the non-motor symptoms of Parkinson's are anosmia,
Yeah,
because they have
exactly.
loss of sense of olfaction, okay? And they
Mhm.
have restless leg syndrome. They have mood disorder in the form of depression and anxiety, and usually constipation. These are the main non-motor symptoms.
Perfect. Yeah. Dr. Henry mentioned a lot of difference between PSP and
Yeah,
Yes.
idiopathic.
Could you
Uh,
please repeat
yeah,
it?
I cannot remember any of them.
yeah.
It's, I
I,
think, beyond the basis exam. This is
Yeah.
neurology point. Anyway,
Okay.
if you can summarize them for us, please.
yeah,
Yeah, just
I think
Uh,
I mentioned it. I said that usually you use certain parameters.
yeah,
The
yeah,
tremor.
yeah, I know Dr. Renar, but Dr. Rabia, she's a neurology consultant. That's why I want to hear it from. I want to hear from here the point or the neurological point of view. We
Okay.
can remember it. Okay.
Okay.
yeah. Dr. Henry was very clear, but these are too many differences, okay? So we'll just stick to few differences in the form
Yeah,
of
give
paces,
us
okay?
the most common and important in basis. Yes, please.
Yeah. Yeah, usually Parkinson PSP is vertical gaze restriction. A
Okay.
patient will not be able to look down. If he look down, he will have some blurring of vision. Okay, in
Mm-hmm.
idiopathic Parkinson, no problem in the restriction. Okay.
Mm-hmm.
Mhm.
Secondly, idiopathic is usually stoop posture, and PSPs usually they have a staring gaze, and they will look very extended posture. They will move with their head up, very
Aha.
extended posture. Okay,
Yeah.
and usually the first presentation of PSP usually falls. Patient will come with a history of falls, that I'm falling, I'm walking, I'm falling, I'm walking,
Mm-hmm.
I'm falling. But
Mm-hmm.
Parkinson usually present as initial symptom as tremors.
Mm-hmm.
Okay,
Mhm.
this is the basic differences. Regarding the management, Parkinson idiopathic usually responds well to carbidopa levodopa. All Parkinson plus syndromes does not respond to carbidopa levodopa very well.
Mm-hmm. Okay.
That is the
Yeah.
main difference. That's
Yeah,
it.
it's golden, really. Thank you. And
Okay.
fair enough to know it or these difference. I think more than this, it would be beyond the paces wise, it would be a neurology exam.
Mhm.
Uh, Thank you, Dr. Rabi, again. The reading
One
as well,
more thing,
right?
Dr. Vasan. One more
The,
thing.
yeah, sure.
Um, Dr. Henry mentioned in the end to complete your examination, I would like to do the push test. Push test is not allowed in PACES, okay? If you
Mm-hmm.
will just give a push or pull test and the patient will fall, you will fail the exam, okay?
The
Yeah.
So
station,
no
Mhm.
need
yes.
for push and pull test in the exam, okay?
Okay. Yes, you're right. Thank you. This is for the welfare. Don't try to do this test ever. Why? Because if the patient will fall, you will fail the station. Not only the welfare,
Mhm.
they will fail you in the whole station. Okay, thank you again, Dr. Rabia. Any missed point you want to add or any suggestion apart from the mention and we have discussed?
No, no, it was all very clear. Just to, Dr. Sara mentioned all the examination and the test, but most important thing we can say it's a clinical diagnosis.
Yeah,
Parkinson is a clinical diagnosis. We'll do imaging to
to rule
exclude
out
Mhm.
other causes like
exactly.
vascular, like
Yeah,
Parkinson plus syndromes. Okay, and no
yeah,
need to mention this DAT scanning because this is a very high level. Okay, for us,
yeah.
if we don't
Mhm.
find anything, we might go for DAT scanning if we want to diagnose early Parkinson. But this is a clinical diagnosis. I cannot diagnose any patient without clinical symptoms and do the DAT scan. Okay, this is
Yeah.
not acceptable. So clinical signs symptoms usually come before the radiological presentation. So for
Mhm,
us, it's most important is the clinical presentation and
mhm.
MRI to rule out other causes.
Exactly,
Yeah,
yes.
exactly. Mhm.
Yeah, so whenever you want to start to roll out and to exclude the other causes. Idiopathic, because of the idiopathic, the term idiopathic means it's clinical one. Otherwise, you want to roll out the other secondary or Parkinson plus syndrome. Thank you, Dr. Rabi, again for your presentation. Yeah. Okay. Let's start the second station. Do you have any case, Dr. Sarah, you can give to Dr. Henry?
Yes, doctor. Um, okay. Mr. Ali examine his lower limb
Okay.
neurologically.
Okay, just give me a second to read the comments. Circumduction gait of, yes, perfect. Thank you, Dr. Al Abu Ahmed. Okay. Circumduction for the hemiplegia. Yes, you will have circumduction gait. We missed this gait. That scan, very important. Yes, I agree to mention any investigation, but after mentioning the full lab investigation. Why? You want to be sure this is not Parkinson plus or to rule out other causes before mentioning advanced image or scan. Okay. Why don't write test in paper? I don't know what is this. What you mean by this? Okay, let's start. And
Microgravia. Microgravia.
yeah, she mentioned write your name in the paper. So
Mhm.
it's
Yes.
yeah. She mentioned it. I don't know if she mentioned that or she mean that or another thing.
Yes, yes.
Okay, Dr. Henry, you ready?
Yeah, I'm ready.
Yeah, here you go.
Okay.
Examine his lower limbs.
Any the name any okay, it's all right.
Yeah,
Um,
Mr. Ali, I think 60, Dr. Sarah,
60 years,
No, no. Yes, 40 years.
40.
40
Okay,
years. Okay.
start now.
Good morning. I'm Dr. Henry, one of the doctors here. I've been asked to examine your legs. May I please confirm your name and age?
Yes, doctor. I'm Ali, doctor, 40 years old.
Okay. May I have your consent to examine your legs, if you don't mind?
Yes, doctor, you can do it.
Okay. I wash my hand. I look look the patient surrounding. Then I ask him, do you have any pain or do you feel any pain on any part of your body, especially your legs?
No, doctor.
Okay. So I look at the surrounding, check for working aid, check for any evidence of scar, check for any evidence of wasting, check for any evidence of spots like some, cafe spots and some other spots in the legs and the part or upper part of the body. Then I looked at check for wasting, any wasting.
There is walking at doctor, and also, yes, there is wasting.
Okay, so where it waste, is it distal or proximal?
Yes, more likely proximal.
Proximal. Okay, so I have to check for fasciculation. Any fasciculation there?
Not present.
No fasciculation in the wasting in the part that is wasted. Okay. Then
Yeah.
check fasciculation. Then after that, check for the bulk. How is the bulk? Any obvious any decrease in bulk in any of the limb?
No.
Okay, then check for the tone. Check for the tone, for both
Mm-hmm.
the left side and the right side. How is the tone like?
How you can check for it?
Please,
Give the instruction.
all right, please, I want to check your joints.
Mm-hmm.
Can you just raise your left leg up and I'm going to put it at 90 degree,
Mm-hmm.
at the level of the knee joints. Then I take it up and down, checking
Okay. There's hypotonia.
the opportunity in the left or in the left and right.
Yeah.
Both,
Both.
both. Okay. Do same in the knee. Do that in the ankle region too. Do in the individual toes and everything. Then since there's hypertonia, same time I'll check for clonus. Any clonus?
No clonus. Negative hypotonia. No clonus.
Okay. Then I want to check your the power. Please, can you please
Mm-hmm.
um take my hand up your pull my hands up your
Yes, he
thigh.
carries. He carries his both. Yes, like
How is the power like both legs?
yes, he carries.
Okay, and is it full power? Football, right?
Not, yeah.
Of
Regarding there is weakness, yeah.
okay.
Weakness in the muscles of the thigh.
Okay. What's the number? Which number will I give the weakness? Is it 4/5 or 3/5? Okay, there's weakness. Lovely. Okay, it's all right. Then do the same thing in
Yeah.
the leg. Any weakness in the leg?
No.
Okay. Then in the toes, everything, no weakness there. Okay. Then I want to please permit. I want to strike you with this hammer. I'm going to do it gentle. I will ensure that
Mm-hmm.
while I'm doing that, while I'm looking at the patient face. So I'm doing the new knee reflex. I strike on the knee reflex. Anything, any hyper reflex or hyper reflex, yeah.
Hyperreflexia.
High reflex are good. Do both leg hyper, okay, both leg hyper reflex, yeah. Then go to the ankle, do the same thing, that strike the Achilles tendon, strike the Achilles tendon, then also do the use my orange board to check for the Babinski sign. Is it positive?
Plantar.
Babinski plantar, yeah, plantar reflex. Is it
Mute plantar.
pardon?
Mute plantar.
Mute.
Yes.
Okay, no, okay, absence of plantar. All right. So I want to do some. After I've done that, I want to do it. I want to. Can you please use your right heel and strike your knee downwards to your ankle? Do it gently, then fast. Any cerebellum, any problem with the cerebellum there?
No.
It's like okay.
Intact.
Okay, then I did both leg. Then after that, I will want to check for this, do the sensory. Please look at this cotton wool. I want to put it in your chest. Can you feel it? Okay, so
Yes, I feel it, yeah,
okay, so I want
doctor.
you to close your eyes. I want to put it in your body. When I place it in your body, and you
One
feel
minute.
Yes, I feel it.
anything, any abnormality s- in the senses.
No.
No, okay. Then you do it
Intact.
using pin, using a pin prick to do something on pain. What of in pain? Anything?
No,
Okay, then
I feel it.
okay,
Yeah.
then do the vibration, test for vibration. Use my turning fork, 1 to 8. Strike anything, any vibration.
No.
You did feel the vibration? You feel it?
Yes,
Okay,
doctor.
then do the proprioception up and down, please. You do feel it up? Is it up or down your toe?
Ye-
You feel
yes,
it?
doctor.
Okay, good.
Intact, yeah.
Okay, then I want to do please can you stand up and walk if you don't mind? I want to assist.
Yes,
How
yes,
is the
the
gate like?
written.
How is the gate?
Yes, he walk.
How is the
Watering
gate?
it.
What
Watering it.
waddling gate?
Yes.
Okay, okay. So after I'm done, I'll then check for um posterior column. Anything in posterior column?
What you want to do specifically for the
Please
posterior column?
Okay.
can you close your eyes and see? Let me see if you can sway. Any swaying on inside?
No.
What you are doing exactly? What's name of this
I'm
test?
assessing for the posterior column. Rhomboid sound. Rhomboid sound.
Romberg.
Sorry.
Romberg.
I'm
Romberg.
assessing.
Okay,
Yes, yes.
Romberg. Okay, negative, Dr. Sir, right?
Negative, yes.
Okay,
Mm.
time's up.
So okay,
You want?
I want to
Yeah, yeah.
Present your case for me, please.
okay. I've examined this 40, is it 45 year 44, right? A 44, this 44-year-old man
Mm.
on
Mm-hmm.
general inspection, there's mobility aid present with wasting of the proximal
Mm-hmm.
aspect of the proximal aspect of the thighs. Then bilaterally, there's no fasciculation. There's hypertonia, hypertonia, reduced power bilaterally, and hyperreflexia. So in generally, with no cerebellar or sensory abnormality. Then there's experience of waddling gait.
Mm-hmm.
My diagnosis here is in keeping with bilateral uh, spastic hemiplegia.
What?
Again, Dr. Meher, please
Yeah,
focus.
my diagnosis here is
Did
bilateral
you
lower
complete
limb
your
spastic.
presentation, doctor?
Pardon?
Did you complete your presentation finding? Present your finding in this
Yeah,
patient?
I said my patient.
Mm.
I've examined this 44-year-old man who
Yeah.
on inspection I noticed there's a mobility aid,
Mm-hmm.
at the bedside. There's wasting of the size
Okay.
bilaterally. There's reduced bulk. There is
Mm-hmm.
hypertonia bilaterally with with ankle clonus. There's
Hypotonia or hypertonia?
hypertonia.
No, your patient hypotonia, doctor.
Okay, hypotonia. Okay,
Yes.
there's hypotonia with
Mm-hmm.
increase with reduced power and increase
Mm-hmm.
hyperreflexia with absence of ankle jerk, and then with waddling gait on
Mm-hmm.
your waddling gait. Then keep my diagnosis is keeping with motor both upper and motor neuron both upper and motor neuron lesion in my patient. Presence of
Mm-hmm.
upper motor neuron lesion in my patient. So my diagnosis here is
What is the sign of upper motor neuron in this patient?
the sign of upper motor neuron is hyperreflexia that he has bilaterally.
He has hypotonia,
Hyperreflexia, Dr.
hyporeflexia.
Hannah. Yeah.
Okay, there's hyporeflexia, hypo.
Yeah, yeah.
Yes,
Okay,
hyperreflexia.
okay, hyporeflexia. Okay, then the
Mm-hmm.
point is with this. Okay, so my patient tends to have flaccid bilateral lower limb
Mm-hmm.
flaccid paraparesis, which is
Okay. What is your differential diagnosis, doctor?
my differential diagnosis here is um, proximal myopathy, likely,
Mm-hmm.
yeah,
Mm-hmm.
likely due to one.
Mm-hmm.
It could be from
Mm-hmm.
it could be from
Okay.
endocrine cause. It could be from which is from hypothyroidism. It could be for um,
Mm-hmm.
what do you call it again? Electrolyte disturbances like hypokalemia. It could be for it could be from
Okay. Another?
yeah.
Any other
Other
differential?
other differentials could be
Mm-hmm.
um, dermatomyositis. If
Okay.
dermatomyositis could be differentials too. Then
Mm-hmm.
what else again? Cause of that.
Okay. If I give you chance to examine more these patients, what do you want to examine for these patients apart from lower limb?
I want to examine the upper limb and then the
Mm.
anal tone and the anal tone
Mm-hmm.
and the bladder.
Okay. Well, doctor. So, what is your investigations?
My investigation will
Workup
include
for this
yeah,
patient?
my workup will include blood
Mm.
test for full blood count differentials, electrolyte and urea, check for liver function test, check for vitamin B12 and thiamine level. Also check for thyroid function test in my patients. Then check for yes. Then I will order imaging such as MRI of the spine spine. I also do other
Why you are do MRI spine for this
yeah
patient?
to rule out radiculopathies. That's yeah to rule out
Mm-hmm.
radiculopathies in my patients, and then also do also for my blood test. I also do hemoglobin A1C, do fasting blood sugar. Then also in my other imaging that I want other tests I want to do is need EMG and
Mm-hmm.
nerve conduction study in my patients.
Okay.
Um,
Okay.
then
So, what is the treatment for this patient?
the treatment may include this multidisciplinary approach, which will include
Mm-hmm.
the neurology MDT, specialized nurse, also the occupational therapists,
Mm-hmm.
physiotherapy, and
Mm.
yeah, social services. Then also as part of the management, our patient will benefit from treat the underlying cause if it's due to the low thyroid. I would give replace thyroid. If it's due to electrolyte abnormality like potassium, will replace. If it is due to if it's due to
Okay.
due to
You
underlying
mean to
cause.
correct the underlying cause?
Yeah,
Yeah.
underlying cause. Yeah.
Okay. Thank you, doctor.
Okay, I will ask him if you want to take history for this patient. What particular history you want to ask about?
Yeah. For this patient, I want to ask the history of the level of the food. If he has evidence of diabetes, to rule out. If you have evidence of diabetes, there's any evidence of food intake or exercise prior to the weakness.
Okay.
Yeah.
If another history or particular history you want to ask, apart from past medical history,
Hereditary too.
he's young patient, 40s only. You
Yeah.
want to ask
Hereditary.
about, yeah, so you want to ask about family history.
Yes.
Okay, I will add one more investigation, very specific to confirm a diagnosis. What is the test you want to do?
Biopsy.
Muscle biopsy, okay. One more test
Yes.
related to the history you asked earlier.
Yeah, potassium level, serum potassium.
No, you asked for the
Genetic.
family, right?
Yeah, genetic study. Sorry,
Exactly, yes.
genetic study.
Okay, fair enough. Thank you, Dr. Inari. Well done. Dr. Sarah, please, can you?
Yes, doctor. Regarding your introductions, you did well. But yes, and also the examination. But I comment regarding the reflexes. Whenever if you find hyperreflexia, we need to ask the patient to clench his teeth. Okay. For reinforcement to be sure that this patient he has areflexia or hyperreflexia. Okay. Um, yes. Uh, your problem in the presentation of these patients, you get, I think, confused to collect your finding in examination because this patient he has lower motor neuron lesion in the form of wasting. Apart from the waking aid beside him, there is wasting. There is a sign of a lower motor neuron lesion in the form of hypotonia, hyperreflexia, okay, mute plantar, and weakness. The shape of this weakness more proximally rather than distal. Okay. Yes, you did the Gait. That is right. And also, when I ask you regarding the differential diagnosis for these patients, just yes, there is endocrine cause for proximal myopathy. Also, there is connective tissue disease. Yes, like dermatomyositis, polymyositis. But the most important here, inherited causes also. That is why we need to do genetic tests and to ask for family screening. One of the genetic tests, one of the inherited causes like Baker muscular dystrophy, like facioscapular humeral muscular dystrophy, Duchenne. Okay, this is important things. And also, yes, when I ask you regarding what other examinations, if I give you a chance to examine it, I need from you to check the facial muscles for facial muscle weakness and the scapula, okay, for winged scapula. Yes, regarding the investigations, actually, no need for MRI for these patients. Just we need to do AMG, nerve conduction study, creatinine phosphokinase, yes, muscle biopsy, as you mentioned it, and genetic test. It is most important. And to look for another endocrine causes according to your case to screen for it. And also we need to check for vitamin D, calcium, because osteomalacia, it can cause also in the history for this patient, we need to ask for family history and for medications or drug history because steroid statin can cause also proximal myopathy. Okay.
Thank you. Thank you.
Yes, this is all of my comment.
Yeah, perfect, Dr. Sarah. Nice case. Thank you so much for this case. I will ask now, Dr. Henry, is there or was there any sensory affection in this
No,
case?
there's no central affectation in
So
this
no
case.
need at all to mention the lumbar or the spine examination. Okay? The MRI here, you will consider, or the examiner will consider overuse or unnecessary tests. Okay, focus on the finding and the presentation. If the patient is proximal myopathy, or as you mentioned, I think you mentioned the waddling gait, and you got the case proximal myopathy. So the history will be all going with the proximal myopathy history, like medication, as Dr. Sarah mentioned, the genetic testing, family history, and you have to know the differential, Becker and Duchenne, facioscapulohumeral dystrophy, as well as the limb girdle. Okay, so all of them, or most of them, autosomal dominant. There is some autosomal recessive disease. So you have to be sure about the family history whenever you have young patients. By the way, from the age of the patient, you can put your differential even without examination. How in this young patient, difficult to have neurological manifestation unless he has family history. Most of the neurological patients are elderly, 60 plus, or if they have comorbidity, they might be 55 plus, or even 50 plus with diabetic, for example, complication. But younger than this, you have to think about familial condition, as in this case, one of the proximity manifestation will be as in our case. Okay, I hope it's clear. Dr. Sarah, I think, summarized the whole proximal myopathy causes, manifestation, and the symptoms. Don't forget to add offering the facial examination for the muscle power, and the test against the wall for wing scapula to diagnose the facioscapulohumeral dystrophy. Okay.
Okay.
Yeah, you have any question?
And my only worry is the age is patient is how old again? 44, right?
Yeah, 40.
40. I
40s,
just feel
yeah.
that why I didn't put those the DMD or Becker's muscular dystrophy. I just felt that they are those ones occur around 20
Yes,
years or thereabout.
general differential, doctor, yes.
Yeah.
Yeah, she
For
mentioned it,
differential
yes.
for the case, yes.
Okay.
Any proximity, you will mention them.
Yeah.
Okay. Oh,
The good thing, you did the examination, all
mm,
examination steps you did, but you forget also the surrounding. And those patients definitely, or most of them, they are dependent on wheelchair, or they are
yeah,
wheelchair
that's true. That's true.
bounded.
Yeah,
Yeah, so
true.
because of the
Yeah,
proximal weakness.
that's true.
Yeah,
Thank you.
yeah. The sensation also, you did examination. The gait is very important. Don't leave neurological station without examining the gait.
Mm.
Mostly the gait may be the clue. As we discussed earlier, the types of gait, and every gait, what it can give you a clue for. The waddling gait is specific one for the proximal myopathy. Okay.
Yeah.
Otherwise, yeah, you did well, but I think you was confused about the hypertonia or hypotonia, hyperreflexia or hyperreflexia. But in this scenario, everything will be lost because this is a peripheral disease
Yeah.
from the muscle, not nerves. Okay, so you will mention the muscle as a cause or pathology. Add to them specific test, which is CK, creatinine kinase, and muscle biopsy might help you in the diagnosis. I would like to take history of medication, family history, and endocrine disease as past medical history.
Okay.
These are the common presentation of proximal myopathy. Anyone has question? Dr. Henry first and Dr. Sarah. Any
No,
suggestion?
Dr. Batia. Okay.
Okay, well done, Dr. Sarah and Dr. Henry. Yeah, some doctors wrote GBS. Okay, GBS, you can mention it if whenever you have acute onset of areflexia, yeah, weakness, ascending weakness mainly, but I don't think it could be as a differential in this scenario. Glenberry, even he cannot have any power, or the power will be less. Okay. Anyway, Dr. Rabia, if she's still with us, she can comment if she has any comment about our case, if she's still with us.
Yes, I'm there, Dr. Basim, but Dr.
Yeah,
Sara was
please.
perfect in the. This is more than enough knowledge for this
Yeah,
case. So
yes.
Dr. Sara was very concise. I don't have to comment on anything. This was
Okay.
perfect.
Okay, for the Guillain-Barré, is it possible to be a differential in this scenario?
No,
No.
Guillain-Barré is a differential for proximal myopathy because it usually affects proximal muscles first. But the patient will not come with this type of weakness and patient will not be able to walk like this, okay?
Exactly,
Usually
yes.
the power
Yes.
is too much decreased, okay? 2 by 5, 3 by 5 like this. And usually sensory will not be intact, okay? So he
Yeah,
will have some sensory loss,
yes.
not like this.
Yeah, plus the history, of course, there is history of infection, and it will be
Yes,
acute of acute onset, not as a chronic course.
exactly.
Yes. Okay, thank you, Dr. Rabia. Thank you, Dr. Sarah again and Dr. Henry. Anyone with question, with comments? No need to call by name. Anyone, please feel free to comment. Any doubts? Any point to be clarified, or you want to clarify something?
Right. I'm sorry. I didn't prepare from
No,
this.
no,
I
it's
just
fair
I
enough.
joined it.
Really, as a topic,
Okay.
you prepare it well, you present it well, and even you summarize at the end very well, as well as Dr. Henry, of course, because he always saves the session.
Yes.
Whenever there is absence, he will present. Thank you, Dr. Henry, again, and thank you, Dr. Sarah. See you tomorrow, inshallah, with long clinical consultation day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
شكرا جزاك الله خير.